next article is going to be an article by Dr. Samir Mehta on the reduction strategies to the anterolateral exposure for fixation of type B and C pilon fractures.
Okay.
So with that, Dr. Mehta, thank you for joining us. Today we're going to be discussing your article on reduction strategies to the anterolateral exposure for fixation of type B and C pilon fractures. This is one of the articles that we decided was a landmark article for pilon fracture treatment. So thank you for agreeing to be part of this.
Thank you for having me. I really appreciate it.
So first thing I got to ask you is what prompted you to write this sort of technical trick article?
Yeah, and I think like anything else in orthopedic literature, it's sort of what was the motivation to do it. And for me and for us, I think there are a couple of things that drive us to write. I think one of the things about technique or surgical exposure articles is that sometimes they're hard to find. They're buried in a book chapter somewhere or in a resource that may not be accessible to most people. And exposure or technical articles, I think, are extremely helpful because at the end of the day, I think what separates things like orthopedic surgery from other subspecialties, aside from the medical part of it, is also the technical part of it. And the technical part of it, I think, can be sometimes very challenging. And so for us, the motivation, or for me, the motivation was this particular technique, while I learned it in fellowship and we used it readily, wasn't something that my residents, when I came back to Philadelphia, really knew about or could even really find a good reference on with imaging, with discussion, with indications. And so that was the driving force to say, hey, listen, this has not really been well described. Similar to the anteromedial article that's been published in a similar fashion to the plafond and other, I mean, there's other articles. And sometimes what often happens is that some of these technique articles, the technical aspect of the surgical technique is buried in a more broad-based paper on the outcomes of the procedure or in a different kind of format, whereas sometimes you just want to know how to do it, right? And so the rationale here was let's write an article on how to do it.
Great. So to start off, you kind of gave a really good explanation of when to do this approach as opposed to doing the anteromedial. Could you just summarize for the listeners?
Yeah, I think there are different ways or different reasons to approach the tibial plafond, and the data is pretty clear that a CT scan is extremely important, and studying that CT will affect your decision making, your surgical planning, and your surgical reduction technique. For the anterolateral exposure, if you have a tremendous amount of medial comminution or you have to do a lot of work on the medial side, the anterolateral technique probably is not the best way to get to the anteromedial or medial side of the tibial plafond. And that's not to say you can't put a medial implant on the tibial plafond through a separate small percutaneous incision if you had to do a little buttress plate, if you're worried about varus collapse or something like that. But if you're looking to do articular work on the medial side of the tibial plafond, then that is not a good reason or not a reason to do the anterolateral exposure. You can do the anterolateral exposure in conjunction with a posterolateral exposure. And Jamie Howard's article showed that the skin bridges are sufficient enough to manage that. So you can get to the back of the tibia or back of the fibula and also get to the front of the tibia through an anterolateral exposure without worrying too much about skin bridges, as long as you are careful with the angiosomes. But if you're looking to do medial work, then go medial. And when I talk about tibial plafonds, it's all about where's the work that needs to be done, and use the exposure that will get you to where the work needs to be done.
Great. Likewise, another thing I really liked about this article is you kind of really did a good job describing the sequence of fixation working from the back to the front, and you really described this dorsiflexed posterior lateral fragment. And you mentioned a couple of tricks, but I was wondering if you could kind of review some of the tricks you used to reduce that dorsiflexed posterior lateral fragment.
So I think there are different ways to get to that dorsiflexed lateral fragment. I think one trick, if you will, is to get the fibula anatomic, and that can help drive some of that reduction. Additionally, using an elevator or a freer to help mobilize that fragment will also help. Getting around to the back of the tibial plafond through a posterolateral incision, especially if that's the incision that you used for your fibula, can also help you approach that posterolateral fragment. I also think the use of a distractor can also help visualization. I can't, the other thing that you can do to really see back there is to use a dental mirror. If your hospital has a dental mirror, they don't tend to fog up. And so you can insert a dental mirror with a distractor into the back of the tibial plafond to really see back there as well.
Okay, great. You describe taking a C-type, OTA C-type fracture and converting it to a B-type fracture. I was wondering, when do you find that to be extremely challenging, and when are you kind of going from a C to an A, sort of?
Yeah, so that's a great question. I think, again, that it comes down to, the question was, when do you convert a C-type to a B-type or C-type to an A-type, and what drives some of the decision-making? I think the number one driver for me in terms of decision-making is the CT scan, and also what's happening with that posterior fragment. If that posterior fragment has a spike that comes up proximally, where I think I can reduce it through a posteromedial exposure, or even through a posterolateral exposure, or I may go prone to get a perfect anatomic read of that indirect reduction of that articular block by getting a direct reduction of the more proximal end of that fracture fragment on the diaphysis. I tend to try and convert a C-type to a B-type. And it's usually with the posteromedial exposure. There's usually a posteromedial spike. And by converting that C-type to a B-type, it makes your anterior exposure and reduction much easier. The challenge comes in when you have these far distal C-type posterior injuries where there's no good way to control it from the front, and they're distal. Obviously fixing the fibula is something we talked about before, but something I like to do. And the CT scan will hopefully give me a clue as to whether that posterior fragment is associated with the distal fibula, and by getting the distal fibula anatomic, can I drive some of that posterior malleolar reduction? So for me, it really comes down to the CT and whether I can get that C-type to a B-type, which is my preference because I'd like to build off a stable posterior foundation. If I can't get the C-type to B-type, then I want to build the articular block first while it's still mobile, rather than malreducing the posterior malleolar component and then having to drive off of that.
Great. Next question is, the challenging osteochondral fragments. Do you have any sort of tricks to kind of provisionally hold it reduced while you're placing your definitive implant? Are you using the talus, the articular surface of the talus as a template? How are you holding it there?
Yeah, so that's always a challenge when you have those small osteochondral fragments. The first thing I do is make sure that they're disimpacted and that they're mobile so that you can get them where they need to be. I use a lot of Kirschner wires and smaller diameter Kirschner wires, so not the 6.2s, but maybe the 5.4s or the 4.5s to really get get a surface that can support that piece. What I will sometimes do is use the distractor, get distraction of the joint first, mobilize the pieces, place my K-wires as a scaffold or a raft, and I'll release the distractor so the talus then pushes that articular fragment back up. I use a lot of dental pick utilization as well to mobilize those fragments. I will actually use intraosseous mini fragment screws as well. So obviously that can be a challenge if it gets infected, but I will try and secure those pieces with some small mini fragment screws. I know there's some people who are using some bioabsorbable type things. I haven't done that. I don't have access to that at my hospital, but there are some techniques and tricks to do using those as well. But oftentimes I am using the talus as a scaffold, but it's only after I've mobilized the fragment, and I've also placed rafting wires to support so that it doesn't overcompress and I lose my reduction.
Next question is, sliding the anterolateral plate while the foot's in the way, especially particularly with longer plates. Do you have any, this was something, I kind of initially struggled with. Do you have any tricks? Do you use counter incision? What's your methodology?
Yeah, so the issue of sliding a long plate quote unquote up the tibia through an anterolateral exposure with the what can be challenging because the foot can get in the way, especially with some of the longer plates. And so there are a couple different options for this. One option is to actually make a counter incision more proximally, or a couple of counter incisions. Sometimes you have to make more than one to help guide that plate as you put it in, then start to turn it and glide it up the tibia. Another option that some people utilize, and I'm not really a huge fan of this, is you can actually insert your plate from top down, but you have to navigate the plate a little bit. You have to, and I've never done this, but I've heard people do this. They kind of get it underneath and they tie a suture to it and they kind of pull it towards them. And I would not advocate for that. I think the counter incision technique works, and it works really well, and it helps actually get your screws in too proximally. And so just have to be mindful of the nerve distally, and making sure that your orientation of your plate is set proximal and distal. Plate balance is really important. So if you are going to use a long plate with counter incisions, pinning the plate proximally, pinning the plate distally, and making sure you've got that plate balance right is really important.
Great. Last question. Got to talk about the new technology out there. Do you find the newer generation plates with that distal tab of screws to be helpful in your practice, or do you still choose some sort of mini fragment fixation, or some of those rafting K-wires as you described?
Yes and no. I think new technology can be helpful. I think it depends on, again, it depends on your fracture pattern. It depends on what those screws are going to do and the orientation of those screws. A lot of times, for me, I'm still using some mini fragment fixation across that very distal articular edge, or some K-wires, and then I'm putting the plate on top. If the pattern allows for it and the mini fragment fixation, or that small fragment fracture fixation or fragment specific fixation, is not quite as necessary, I may shy away from using a mini fragment plate and use one of these newer implants that allows me to put screws as quote unquote rafters or really distal. A lot of these newer implants have a really small row of screws, just like 2.4 or 2.7 screws, and then the bigger, more macro small frag screws more proximally. So I think it really is dealer's choice. I think you have to be mindful that you don't want your implant to drive your reduction and drive your screw application. So if I find that my implant is not letting me put my screws where I need to, then I'll use a different implant, like a mini frag plate, put my screws where I want them to go, and then back it up with larger fixation.
Great. Thank you so much, Dr. Mehta. That was a very great comprehensive review.